look forward to your inputs in the next two talks. The next one is going to be on unilateral cataract. And the players here are Dr. Nivean, who's Director of Academics of the MNI Hospital Private Limited, Chennai, and of course, a very dynamic anterior and posterior segment surgeon. And he is going to tell monofocal IOLs is the only choice in unilateral cataract. And contesting him is going to be Dr. Naren Shetty, who's a vice chairman of the Narayan Nethralaya group of hospitals, and again, a very versatile cataract surgeon. And he is going to say multifocal IOL is the option. So quite daring. So with these two, with their talks, we have an expert view to be given by none other than Dr. Vinu Matan. So let's look forward to a very interesting debate. On to you, Nivean.
Thank you, ma'am. Can you hear me?
Yes, yes.
Yeah. So respected teachers, senior ophthalmologists, my dear friends. So the topic given to me is unilateral cataracts, monofocal versus multifocal IOLs. One second. Yeah. So the presenter, that's me. I do not have any personal preference to any person, product, or the company. So what I'm going to talk about is my personal opinion. Yes, backed up by some literature and might differ from others. I know that I can't defeat Naren in two things: his charming looks and his research and theoretical knowledge about all the different types of IOLs. So I'm just going to keep it very simple and easy for all, and make sure that monofocal IOLs will score over multifocal IOLs when it comes to unilateral cataract. So let me be very clear that we are not talking about operating the other eye anytime soon, or the surgeon or the patient wanting for the other eye refractive lens exchange. Because in these conditions, even my choice would be to go for a trifocal IOL, but not multifocal. So what are the various scenarios that we can have a unilateral cataract? We can have it in congenital syndromes. We can have it as secondary cataracts. We can have it trauma. We can have it during posterior subcapsular, during any steroid-induced cataracts, or pediatric cataracts, or idiopathic. So as long as congenital cataracts are concerned, I definitely prefer a monofocal IOL, because we all know they're always usually associated with some syndromes and also other comorbidities, like they have associated glaucomas, they have associated retinal problems. And we know that if you don't have a good optical system, then any of these multifocals do not work 100%. So even in the literature search, there are a lot of cases only about how to undercorrect and how to get a perfect hemotropia using monofocal IOLs, and no published articles about using multifocal IOLs in these type of cases. So the second point, in pediatric cataracts, yes, again, unilateral pediatric cataracts, there have been a lot of studies done, and we all know how the myopic shift can occur after a few years. And in conclusion, they have told, yes, I'm not going to the common side effects like glare, halos, and other things, but they also have that waxy type of a vision. And also there have been a lot of reports of explanting these multifocal IOLs in the later part of the stages of the life. So moving on to traumatic cataracts, yes, we know it can have a tone anterior capsule. As we all know, we need a good centration for any of these multifocal lenses. So when we lose the anterior capsule, we're not able to keep multifocal lenses. And all these traumatic cataracts unilateral will have some amount of zonular weakness or the irregular pupil size. And that is again going to cause distortion when it comes to pupil-dependent multifocal IOLs. And also they can have a pre-existing rupture. So you don't know the extent of the rupture. So again, here it rules out in unilateral traumatic cataracts the use of multifocal IOLs. So basically, yes, I don't have to highlight between monofocal and multifocal. Monofocal always gives you a very clear distance vision. So there is no complaint as far as the distance vision is concerned. We always go for the quality of the vision. Yes, quantity wise, we can give both 6/6, but then the quality of the vision again depends on the contrast and the amount of light loss, which is not there in monofocal IOLs. And yes, in case later on you want to do the other eye, you can always go for a small bit of myopic shift up to 1.25. So you can have some amount of intermediate and near vision using monofocal lenses in the other eye. And whatever residual refraction is there, the patients are always happy with their glasses. But multifocal, sometimes depending on the other eye's refractive error, the patient gets confused whether they'll have to wear glasses or there's no need for wearing glasses. So in that case, again, the whole purpose of doing a multifocal uniocularly is lost. And then the neural adaptation. There's so much have been spoken about neural adaptation and so many different combinations that have been tried. But I think the recent conclusion is whatever you go for one eye, make sure the other eye also gets the same type of IOL. So yes, again, these are some of the common things with all type of multifocals, the glare, halos, loss of contrast. And it doesn't matter whether they're the advanced multifocals or the newer generation multifocals or the trifocals. In all these cases, only these symptoms are reduced, but they're not that it is not there. So these things are not there in any of the monofocal IOLs. So we all know when we have clear focal point, we have clear vision. So whether we do an EDOF lens or any multifocal lenses, there is a blurring of these letters because that elongated focus only gives you that 2 or 3 point focuses, and it's going to lead with glare, halos, and starburst, and so many other phenomena. And we don't want to see these type of lights when we drive or do other activities in the nighttime and low light. And in case we have something like a residual power that is left or any surgically induced astigmatism later on, and that leads to the loss of vision, it is very difficult to convince these patients who have multifocal IOLs where we have promised them very good distance and also good near vision all the time. So coming to the last scenario, in case of idiopathic unilateral cataracts, like usually between the age of 45 to 55, and they have just one eye cataract. So what could be the possibilities of the other eye? Could I either have a high or low refractive error? So patient is basically happy with the other eye vision using his glasses. So here again, the choices would be an advanced monofocal or a EDOF lenses as compared to any multifocal lenses if the patient is not motivated enough to get the other eye immediately done. So basically, you just have a good target for the distance vision. As I said, eventually, if the patient again wants to do the other eye also, you can do like a micro mono vision. So then you also get some amount of intermediate and near vision. Yes, you do get surprisingly good results, and all of us have done it with monofocal IOLs like this when reading 6.5 and 8. And again, all these things depend upon the higher order aberrations of the cornea and also all the positive spherical aberrations in these lenses. So there is various other factors and also one beautiful factor called the pseudo accommodation. So it's basically a complex phenomenon which depends on the pupil size, the against the rule cylindrical refractive error, and the multifocality of the cornea. So all these things, when you go for a monofocal, I think it's a lot safer to get your predictable results. So what will happen to these patients, 50-year-olds, which are doing 10 years later, 20 years later? I know it doesn't stay the same because as we age, the eye also ages, and then there is a shift, and then there's a loss of more vision when you have multifocal lenses, when there's severe dry eye, other corneal degenerations, or long-term any retinal pathologies that may develop due to age. So I would fail if I don't talk about the cost. Just for the completion, it's like comparing generic shampoo against all the branded ones. So cost is also one of the effect in giving something better. And then for this, you'll have to open influences to make sure that that multifocality is working. So it is not only the lens that is doing. So you will also have to do a lot more effort to making people understand. Yes, there may be increased profits when it comes as long as when you do a multifocal IOLs or a trifocal IOLs, but I'm sure that my moderator here doesn't go by just the cost. So once again, if you're not talking about operating the other eye and the surgeon or the patient doing the other eye, my choice would be monofocal. But then said all this, in this current era of the newer generation trifocals, and with all the lesser amount of glare and halos that it causes, and trying to give something better to the patient, I would consider the trifocals also, because I asked my friend to help me with a few points about my talk, and then he sent me a slide in which he said that use trifocals, they're slightly better. So there is an advantage when you use trifocals, I think, in the current scenarios. So I think it's good to know both sides of the coin and use it judicially, depending on what the patient wants and not what we just go for, what is the best. So in conclusion, I would say treat the patient according to what is best suited for that particular individual. Yes, we have all the publications and the guidelines, but they cannot be just followed blindly. So patient's needs is the most important key in choosing the right IOL. And it is not just what is best, what is the best IOL that is available in the market. And yes, to get the good results, we also have to go with good surgical skills and proper planning and biometry. It is not only the lens that's the everything. There are other key factors in getting the surgical technique right. And yes, quality over quantity, because we know a lot of these 6 patients who are unhappy, but we really don't get that many complaints when you go with a monofocal IOL. So once again, thank you, Dr. Chitra, ma'am, for this wonderful opportunity, and the Eye Foundation for this. Thank you.
Thank you. Thank you, Nivean.